Physicians are frequently confronted with patients who present with low back pain. Some 60 to 80% of the population will have at least one disabling low back episode in their lifetime. Unfortunately, we can only make a firm anatomical pathological diagnosis in some 20% of those people. That is wherein the ability to do structural diagnosis and manual medicine procedures in the lower back is helpful in managing some of those patients. Now, the lumbar spine and the pelvis contribute a great deal to lower back and leg pain. In the lumbar spine, we have the 5 lumbar vertebrae, most people, and they are related to the lumbar vertebral bodies in front, the intervertebral discs between, and the posterior arches, which include the spinous process, the transverse processes on each side, and the facet joints on both sides. Now, the orientation of the facet joints in the lumbar spine is primarily vertically, and it provides for a fair amount of flexion and extension movement. And as it flexes and extends, the facets will open and close. There is a small amount of side bending movement in the lumbar spine. Again, as each of the facets move together in right side bending, the right facet will close and the left facet will open, and in left side bending, the left facet will close and the right will open. Now, there's a very small amount of rotation which occurs, and that will couple with the side bending either in neutral mechanics. And neutral mechanics, remember, are when the lumbar spine has all of its curves present. When the normal lordosis is present, the normal coupling of lumbar spine is side bending and rotation to opposite sides. Neutral mechanics of side bending and rotation to opposite sides. Now, the non-neutral mechanics in the lumbar spine occur when it is forward bent. And when it is forward bent and you introduce the side bending, rotation occurs to the same side physiologically. So that we have in the lumbar spine the capacity for normal neutral mechanics and the non-neutral mechanics in forward bending. Now, any of those can become dysfunctional. We can have a lumbar spine dysfunction in both neutral and non-neutral mechanics. The neutral group dysfunction is the one that's the most easily seen because we see a whole group of segments that have become side bent to one side and rotated to the other. We can see that curvature quite easily on the patient. When that has occurred with side bending right, rotation left, the rotation has taken and made a fullness on the side of the convexity. Now, when that is retained, for whatever reason, usually muscle tightness on the concave side, no matter what position we put the patient in forward bending, neutral, or backward bending, those 3 or more segments will retain that position of being posterior on one side. The motion restriction then would be when it was side bent to the right and rotated to the left, as this example. The motion restriction is then side bending left and rotation right. Now, in manual medicine, we want to try to restore that symmetry as best we can. The non-neutral dysfunctions that occur in the lumbar spine are 2, and they can be described as a dysfunction in which one of the facets loses its capacity to open, or one of them loses its capacity to close. Now, if we take as an example this L4, L5 junction here, this left facet loses its capacity, this left facet loses its capacity to open, what has happened is it is in a closed position and restricted there for some reason. Therefore, the segment will be extended side bent to the left, and rotated to the left. Recall, if you will, non-neutral dysfunctions are described as occurring within one vertebral motion segment only, just one vertebra on the other, and it's named for the superior vertebra on the inferior. Now, if in our example this left facet loses its capacity to open or flex, it restricts the capacity of the lumbar spine to flex in a forward bending moment at that segment. We lose that capacity at that segment. And we also lose its capacity to side bend to the right because it does not have the capacity to open up on that left side. Therefore, the motion restriction is flexion, right side bending, and right rotation. Another way of describing that dysfunction is positionally. It is extended, side bent, and rotated to the left. In other words, this facet being restricted holds that segment in that position. Any manual medicine procedure then will be directed toward opening that facet into a flexion mode to reestablish flexion capability, right side bending, and right rotation. The second non-neutral dysfunction is the one in which a facet loses its capacity to close. Let us take for an example that L4-5, where we were just a moment ago, loses its capacity to extend or close. Something prevents that from happening. So the left facet is neutral, where it belongs. The right facet is fixed in a flexed or open position. In the motion restriction that then occurs is the inability to extend, because that facet does not have the capacity to do so, while the normal left facet does. It also loses its capacity to side bend to the right and the coupled motion of right rotation. So when the right facet loses the capacity to close or extend, we have motion restriction of backward bending, right side bending, and right rotation. Positionally, we could describe that same dysfunction as that L4 is flexed, left side bent, and left rotated. Motion restriction, which is just the reverse, would be extension, right side bending, right rotation. Any manual medicine procedure then will be directed towards giving that facet the capacity to close, to restore extension, right side bending, and right rotation. Now, to make a diagnosis of these dysfunctions, we will ask our patient to move in 3 different positions: full forward bending, neutral, laying prone on the table, and then into backward bending maneuver while the patient is also on the table. Based upon the behavior of the lumbar spine during those 3 positions, we will be able to make a diagnosis both of individual segments that are dysfunctional, or if the whole group of lumbar segments has become dysfunctional. In making a specific diagnosis of dysfunction in the lumbar spine, this can be done at the same time we were doing the seated flexion test, where we will follow that with evaluation of the lumbar spine itself. Recall, if you will, that the seated flexion test is done with a patient sitting, weight on their feet, knees apart. You find the most posterior and inferior aspect of the posterior superior iliac spine, maintaining contact, and ask the patient to bend forward. Bend forward. And as we do, we follow the posterior superior iliac spine as a function test of the sacroiliac mechanism. While we're right here, we can now evaluate the position of the lumbar vertebra in forward bending or flexion. From the posterior superior iliac spine, we'll go medial, ventral, and a little cephalward, and we're on the posterior arch of L5. On Mark, we find that relatively level. We move up to the transverse process of L4, and we find that the left posterior process is more posterior. The left transverse process is most posterior. We go up to 3, and we find that it also is more posterior on the left side. Also a 2, and when we get up to 1, they're pretty level again. So what we have is a long group of posterior transverse processes on the patient's left side, and it seems to begin at 4, with L5 being relatively straight or level against the coronal plane. Come on back up now, Mark. We will then move from here to evaluate him on the table in the prone and the extended positions. Proceeding with the evaluation of the lumbar spine, we now have our patient prone on the table with their feet over the end of the table, and we identify L5 again by finding the posterior aspect of the posterior superior iliac spine, moving medial, ventral, and a little cephalward, and we drop into the posterior arch of L5. Now in the neutral position, it is level against the coronal plane. We come up to 4, and now in the neutral position, it is not as posterior as it was when he was forward bent, but 3 is posterior on the left, 2 is posterior on the left, L1 is just a little. By the time we get to 12, we're back to level. So we still have this fullness in the mid to upper lumbar spine on the left side with fullness, convexity to that side. Now we'll ask our patient to go into extension by putting your elbows on the table and your chin in your hands and letting your stomach relax. Okay, orienting again from the posterior superior iliac spine, medial, ventral, and a little cephalward. L5 is level. 4 is totally level at this point. 3 is still a little posterior left, as is 2, as is 1, and 12, we're symmetrical again. Therefore, this lumbar fullness and convexity to the left is retained in all 3 positions, both forward bending, neutral, and backward bending. So we have a group dysfunction that starts at 4 and goes up to L1. Down flat for me, if you will, Mark. In the forward bent position, remember, L4 was posterior on the left side, but it is level in backward bending. That tells us that L4 is restricted in forward bending, right side bending, and right rotation, or it is an ERS dysfunction to the left. He then has a group dysfunction on top of it. And we would have to treat out these 2 dysfunctions and then back and reevaluate the lumbar spine to see if there are any more dysfunctions within it. In summary, on Mark, we had the following findings. When he was seated and forward bent, we found that L4 was more posterior on the left than it was on the right in relation to a level L5. When he was in the neutral position, he was still a little bit posterior left, but not as bad. But when we had him go into the backward bending position on his elbows, we found that L4 transverse processes were level in relation to 5. Therefore, we knew we had a single segment dysfunction at L4 on L5. Remember when we looked on the skeleton that if a facet does not open, it restricts forward bending, right side bending, and right rotation if it is the left facet that is restricted. And that is in essence what Mark displays for us, in that in forward bending, his left transverse process became more prominent. Therefore, he restricted forward bending or flexion. He also restricted right side bending and right rotation at L4 on L5. Therefore, positionally, the segment was extended, left side bent and left rotated, or we can describe that also as E for extended, R for rotated, S for side bent, left. And its motion restriction was forward bending, right side bending, and right rotation. All of that was due to the fact that the left facet's behavior was as though it would not open or flex. The second dysfunction that Mark displays for us is this persistence of fullness on the left side. The transverse processes of 3, 2, and 1 were persistently posterior in the forward bent, neutral, and backward bent position. That is a group dysfunction of L1, 2, 3, down to 4 that has rotated left and side bent right. There is a left-sided convexity, a persistent left-sided fullness. Diagnostically, it is right side bent, left rotated. Its motion restriction is left side bending and right rotation. That is a group or neutral dysfunction from L1 to L4. We so far have not identified any extension restrictions in any single segment of this lumbar spine. We may find some later on after we treat out the two dysfunctions that we currently have identified. We will begin to treat Mark's lumbar spine by addressing the dysfunction at L4-5. In L4-5, we identified that the left facet would not open well. I've identified the two sides of that left facet with the black tape for you. Then the functional characteristic is that this facet, for some reason or other, is unable to open or flex. So our technique procedure will be designed to attempt to open it so that we can restore flexion, right side bending, and right rotation. And we will do that by flexing down from above, flexing up from below, then we will side bend and rotate him to the right from above, and side bend him more to the right from below, trying to get this facet to open in that fashion. I have marked on Mark some landmarks. This is the posterior superior iliac spine on each side. This mark represents the spinous process of L5. This is the spinous process of L4, the two transverse processes of L4, and this X overlies the left facet, which we are going to attempt to open and make it have the capacity of flexing, right side bending, and right rotating. To do that, we will use a muscle energy technique. We will start by having Mark put his arm on the table, slide over to me just a little bit. Now, let me flex your knees and roll you on your right hip. Now, the first thing I will want to do is to engage the resistant barrier of flexion. Remember, this segment does not forward bend, and the first barrier to that is the one I want to palpate. I will palpate on the interspace between 4 and 5 and flex him down a little from above until I first feel 4 begin to move and stop right there. Reverse my hands, monitoring at the same level, and I will flex him up from below until I first feel 5 begin to move, so that the localization to the flexion barrier, both from above and below, is done. Now, when I put Mark in this position, note, if you will, that with him perpendicular on his hip and his shoulder out from under him, that he is right side bent and right rotated. And so we have him in the directions of his motion restriction. Now, I will fine-tune the right side bending by dropping his feet off the end of the table until I first feel that segment begin to move. That's the first barrier to right side bending. The muscle energy component will be, I will resist his feet going to the ceiling, which is a left side bending effort, and monitor the muscle contraction overlying the facet joint on the left side. All right, Mark, if you will just give me, lift your feet to the ceiling, some 3 to 5 seconds of activity, relax, and as he relaxes, I can then flex him just a little more, increase his side bending to the right, give me another effort of lifting your feet to the ceiling, and I resist that with my right hand. Relax, and relax. Now one more time. Lift your feet to the ceiling and relax. 3 to 5 efforts are usually sufficient to overcome the resistant barrier. One last time. Lift, relax. We stretch the muscle out. Then we will return him back to neutral. And to reevaluate him, we would have to sit him on the stool to see if we had restored forward bending movement in a symmetrical fashion between L4 on L5. The last phase of any treatment is re-examination to see if you've accomplished your objective. In the event that the muscle energy procedure was not successful, we might want to contemplate the use of a high-velocity procedure, again designed to open the facet of L4-5 on the left side. Recall, if you will, that left facet is closed, it's extended, left side bent, left rotated. So that the procedure I want to do is, with him in the left lateral recumbent position, the most posterior transverse process down, I'm going to flex down from above, flex up from below, side bend him to the right, rotate him to the right, and then I'm going to put a vector of force on his pelvis that will take the pelvis anterior and cephalward on the top side, opening up that facet on the bottom. On our patient, we will start with him lying in the lateral recumbent position, the most posterior transverse process of L4 being down toward the table. We will monitor at our L4-5 junction, and we will flex him down from above until we first feel 4 begin to try to move and stop there. Change our monitoring hand. Flex him up from below until we first feel 5. Fine-tune that flexion. We've engaged the flexion barrier. Note that in this position, with his shoulders perpendicular, his pelvis perpendicular, we have a right side bending introduced. And so if we take his right arm backward and control his upper trunk, we can introduce the right rotation necessary. Monitoring at the interspace between 4 and 5, I will now drop his top leg over the bottom one, letting his foot hook into the popliteal space. I make a contact point on his pelvis because I'm going to want to rotate his pelvis forward and cephalward with my thrusting effort to open that facet on the bottom side. We will fine-tune the localization from above and below, and instead of trying to make a thrusting effort with an adduction movement of my arm, I'm going to have the arm become part of my body and use my body as the thrusting effort. Stabilize from above. This is not going to be a moving hand here. One moving hand only will occur. This only holds and stabilizes to our localization. We take up all of the slack, and then we will use as a thrusting force a ventral and cephalward direction on his pelvis. Give me a breath in, Mark, and let it all out. That'll get him relaxed, and then we thrust forward, opening that facet on the bottom side. Again, as in any technique, we would go back and reevaluate had we restored the functional capacity of L4 on L5 into the forward bending direction. In the treatment sequence of the lumbar spine, as anywhere else in the spine, you will treat the non-neutral dysfunctions first, then treat the neutral group dysfunctions second. In Mark's case, remember, we had a group dysfunction from L1 to 4 that was side bent right and rotated to the left, and resisted side bending to the left and rotation to the right. So now we want to use a muscle energy procedure to attempt to restore the functional capacity of the spine into left side bending and right rotation. With Mark in the right lateral recumbent position, we have his convexity up. The fullness of his lumbar spine is on the left side, and he's convex to the left. That is the result of the left rotation and the right side bending. But in the lateral recumbent position, with his shoulders perpendicular and his pelvis perpendicular, we have started him into left side bending, which is the barrier to which we want to overcome by our technique. Remember, this is a neutral group, so we want his lumbar spine in the neutral range of flexion and extension. So we will flex and extend him from below, monitoring over that group curve, particularly at the apex, noting where in the flexion or extension arc he is the most free or neutral. When we identify that, we are going to introduce left side bending and the coupled right rotation that follows by lifting his feet toward the ceiling. That starts him into left side bending and right rotation. Now the muscle effort we're going to have him activate is right side bending by pulling his feet down to the table. Pull them down. We don't let it move, so that's an isometric contraction. Relax. We monitor overlying the right paravertebrals. When we ask him to pull again, we should feel them contract. Pull down again. We feel it underlying the long paravertebrals on the right side. Relax. Following that isometric contraction, we can stretch him to a new resting length, enhancing left side bending, right rotation. One more time, Mark. Pull it down. And relax. And we always stretch after the last procedure. Then we will roll him back on his stomach to reevaluate if that fullness that we previously noted on the left side in the neutral position as well as flexed and extended is less prominent than it was before. If in the treatment of that neutral group dysfunction of Mark's by the muscle energy procedure, if we found that not as successful as we wanted, we may want to then again use a high velocity procedure. Recall, if you will, that our pathology is that the lumbar spine is side bent right and rotated left from L1 down to 4. And what we want to do is introduce a procedure that will side bend him to the left and rotate him to the right. And we will do that and put a thrusting force through the pelvis in a straight anterior rotary fashion to introduce our motion. We will start with Mark lying in the lateral recumbent position, supported by his pelvis and his shoulders. His most posterior transverse processes are down toward the table. And note in this position that with his weight on his shoulders and his pelvis, we have his lumbar spine and the rest of his spine in a right side bending position. That is the position of his dysfunction. We want to change that to introduce side bending to the left and rotation to the right. Now, to accomplish that, we will again monitor over the segments of our dysfunction, and we will flex and extend him from below until we can find the point of maximum ease of that lumbar spine. No flexion, no extension, point of maximum ease, or neutral. When we have him in that neutral range of flexion and extension, we will now introduce left side bending by grasping the upper part of his left arm and pulling his shoulder out from under him and in a caudad direction. What that now does is introduce a left side bending of his lumbar spine. Now we will want to right rotate him, so we will control his upper trunk, take and drop his top leg over in front of the bottom leg, make a contact with my forearm on his pelvis in order to take it in an anterior rotary direction. Our thrusting force will be all pure rotation anteriorly on his pelvis. We roll him together until we get localization of the left side bending right rotation to our dysfunctional segments in the curve. The lower in the spine the curve is, the more the shoulder goes back. The higher the curve, the more the pelvis comes forward. In his instance, we want to take the apex of his curve perpendicular to the table, localized there. We take up the slack by rolling him forward from below, backward from above, right rotating these lumbar segments. Take up all the slack, and then with a body thrust, we will move straight forward on his pelvis in that direction. That introduces left side bending, right rotation. Many times it's necessary to do it 2 or 3 times in that group to address all of the segments within the group. But usually if you address the apical segment, that's all you need to do. Again though, you must go back and put the patient in the diagnostic positions of forward bending, neutral and backward bending to see if you have restored function to this upper lumbar group and that those transverse processes are more symmetrical in all 3 positions. So far in Mark's lumbar spine, we have treated a non-neutral dysfunction at L4-5 that had failure of opening of the left facet. It was an ERS to the left, that is, it's extended, left side bent, left rotated, resisted, flexion, right side bending, right rotation. Then we treated his group dysfunction from L1 to 4 that was side bent right and rotated left, and which resisted left side bending and right rotation. Following that, on reevaluation of Mark, we find that 5, 4, 3, 2 are all nice and symmetrical in the neutral position, but when we get to L1, the left transverse process is still a little more posterior than the right. We have the sense that L1 is rotated to the left. Now, what we need to know is what happens to it in the backward bending direction. So get up on your elbows, put your chin in your hands again, and then let your stomach settle. And as we do that, we find that the left transverse process is more posterior in this position than it was in neutral. In other words, it got more asymmetrical. Drop down flat. Now, that physical finding tells us that the left facet was able to close in backward bending and the left transverse process came posterior, but the right facet lost its capacity to close in backward bending, holding the right transverse process anteriorly, so that the more he came into backward bending, the more this became prominent. This right facet does not close. Therefore, the segment positionally was held in flexion, left side bending, left rotation, resisted extension, right side bending, and right rotation. Now, in order to address that, our manipulable technique will be to close the right facet at L1 on L2. Our diagnostic procedure told us that Mark had restriction of motion of the right facet of L1 on 2 in that it would not close into backward bending. We found L1 positionally flexed, side bent to the left and rotated to the left. So our procedure now will to take him into extension, right side bend him, and right rotate him so that that facet joint will close and we will be able to restore the motion of extension, right side bending, and right rotation. We start with Mark in the left lateral recumbent position, again with the most posterior transverse process down toward the table. With him supported with his shoulders and his pelvis, his spine adopts a right side bending posture. Now what we want to do is to enhance extension, right side bending, and right rotation, and to close this facet on the right side. We start by grasping his trunk at that level of dysfunction and translate him from posterior to anterior, introducing extension and localized at that segment. We fine-tune the extension from above, maintaining his shoulders perpendicular, and we will just slide his shoulders back just a little until we first feel the feather edge of L1 beginning to move. We will fine-tune the extension from below by extending his lower extremities and his pelvis until we first feel L2 begin to move. Now at that position we have extension from above and below, right side bending. To introduce right rotation, we will ask Mark to reach down behind him and grab the edge of the table. We've introduced right rotation from above. It also enhances the right side bending from above. Continuing our monitoring at our segment, we take his right leg and lift it toward the ceiling, introducing more right side bending. The muscle energy effort will be to ask him to take his right foot to his left knee, and I will resist that. Pull your right foot down. Relax. I should feel the muscle at that level, deep muscle, contract. All right, we will fine-tune with a little more extension by pulling forward with our fingers at the segment, a little more extension from below, a little more side bending from below to the next barriers of extension and right side bending. Pull your right foot to your left knee. Pull it straight down. Relax. And one more time. Pull it down. And relax. And stretch that last time so that we have stretched out the segment at L1, 2. We would now return him back to his stomach and reevaluate in the prone neutral and extended position to see if we have changed the behavior of L1 on L2. A slight modification you might want to use at times, particularly in people who have knee dysfunction or problems of the ligaments of the right knee, is to control the whole leg and ask him to pull his right knee down to his left knee. That therefore protects the knee more than if you hold out more distally toward the ankle. If we found that the muscle energy procedure for this L1-2 dysfunction of our patient on the right side, if that was not successful, we may want to use an activating force of high velocity, low amplitude thrust. Now to do that, we start in the same position with Mark in his left lateral recumbent position. We will again localize to our L1-2, translate him from posterior to anterior till we first get to the localization at L1-2. We will maintain him right side bent by keeping him on his hips and on his shoulders, fine-tune from above by extending him from above down until L1 first moves. Now we will extend from below until L2 first moves. So we have extension localized. We have him started into right side bending. Now to get the right rotation, I will just take his shoulder behind and stabilize his upper trunk. Keeping the bottom leg on the table, maintaining the extension from below, I just drop his top leg off in front of him, making a contact, again for high velocity, on the pelvis with my forearm. And again we will localize to keep L1-2 perpendicular to the table. Stabilizing from above with right rotation, introduce some right side bending from below, take up all of the slack, and the thrust will be on the hip in an anterior and cephalward direction in an attempt to close the facet on the right side. We will take up the slack, breath in, all out, and the thrust goes in that direction. Now this is a closing facet thrust, and most closing facet thrusts do not give you any pop, so don't expect to hear a popping sound with this particular technique. Opening facet thrusts frequently will. Closing facet thrusts do not. The noise is not the important thing. Did you recreate the normal motion that should be present at that segment? Again, we will want to take Mark back on his stomach, evaluate in the prone and extended positions to see if the functional behavior of L1 and 2 has been restored. Reviewing the structural diagnosis and manipulative techniques for the lumbar spine, recall that we had 5 lumbar vertebrae that have the capacity for neutral mechanics of side bending rotation to opposite sides when the lumbar lordosis is present, and it has the capacity for non-neutral mechanics when forward bent, side bending, and rotation go to the same side. We defined 3 different diagnoses that can occur within the lumbar spine of dysfunctions. They are the group dysfunction and the extended side bent rotated dysfunction, the ERS dysfunction, and the FRS dysfunction, one that is flexed. Those are the ones that have difficulty with facet movement. In the diagnostic process, we had you forward bend the patient and monitor the behavior of the transverse processes posteriorly. When in forward bending, we found that one transverse process became more prominent than one on the opposite side. That identified for us the inability of that facet to open. Therefore, this facet was positionally extended and the joint was restricted in flexion, side bending, and rotation to the opposite side. When we had the patient in neutral, we could identify the behavior of the rest of the transverse processes. We found some posterior transverse processes in the upper lumbar spine. Then we had the patient backward bend in the sphinx position on the table and monitored the transverse process behavior again. When one transverse process came back toward us in relation to the opposite, we identified that one of the facets did not close, or a segment that was flexed, side bend and rotated to one side, and had extension, side bending and rotation to the opposite side as its restriction. In other words, a facet that would not close. So the behavior of these transverse processes in forward bending, neutral, and backward bending was the clue that gave us the diagnosis of a facet that would not open or a facet that would not close. The group dysfunctions were identified by a number of posterior transverse processes on the same side. We then provided both a muscle energy and a high velocity technique to deal with each of those 3 different dysfunctions.